Okay, welcome everybody. This is part of our Energy Grant seminar series from the NIDDK at the NIH. Today we have a really wonderful presentation by Dr. Dominic. Now, I want to make sure I get the last name pronounced correctly. Is it D'Agostino? Did I get anywhere close?
Yeah, that's right.
Okay.
D'Agostino or D'Agostino. Yeah, that's right.
Okay, great. Excellent, excellent. And I'm going to introduce him briefly and then let him run the show because it should be a really great talk. And so I in in preparation, Dominic, I was sort of tracking down your bio so I can introduce you. And I was like, well, I'm going to try ChatGPT for bio and then like compare it against reality and see how good it is. And I was getting through it and I was like, this stuff can't be true. This has got to be hallucinations. But then I I cross-referenced it on your website and it looks legit. So you tell me when and if this has gone astray from reality, when we're getting into hallucination zone. But Dr. Dominic D'Agostino is a tenured associate professor in the Department of Molecular Pharmacology and Physiology at the University of South Florida. He also serves as research scientist at the Institute for Human and Machine Cognition. His academic background encompasses neuroscience, molecular pharmacology, nutrition, and physiology. Dr. D'Agostino's research focuses on metabolic-based therapies, particularly the ketogenic diet, which I'm very excited to hear about, and exogenous ketone supplementation. His work explores their applications in treating conditions such as epilepsy, neurodegenerative disease, cancer, and central nervous system oxygen toxicity. Now, this is where I thought we were getting into a hallucination zone. Notably, he has investigated the use of ketone supplementation to delay CNS oxygen toxicity seizures, a concern for Navy SEAL divers, and has worked with NASA NEMO 22 mission, where he tested ketone technologies developed at USF. And then I tried to find pictures of this. I was like, he was not on a NASA mission. That's insane. And then I saw you in like diving gear under extreme pressures with a bunch of NASA logos in the background. So unless that's also AI generated, that seems pretty outstanding. So was that correct bio? Did we get that right?
Yeah, that's right. And the NASA stuff too was part of a space analog mission. And NASA trains their astronauts. Some of them, you know, are on the space station now, underwater. Like a lot of people don't realize that. So for that, we trained at the Neutral Buoyancy Lab, and we have the opportunity to work with astronauts. And I kind of headed up the research. We had like 5 IRB protocols of research on space analog missions. So we have, astronaut, you know, fecal samples. We have microbiome analysis that we're doing now from different missions, and we look at various aspects of psychology. Looking at different aspects of anxiety, mood disorders, things like that. My wife was on NEMO mission 23, and I was on NEMO mission 22.
Wow. Okay. Well, we're going to have to get you back to talk about that as well. But just an incredibly fascinating career. So amazing. We look forward to the talk. So go ahead, take it away.
Okay, great. So I'll share my slides here. Let's see. Oop. Can you all see that?
Yeah, but we're not seeing
Oh,
the presentation mode, but we are seeing the slide deck.
okay. Can you see that?
I still see like maybe
Oh,
12 slides on the screen.
got it. Uh, let me see. So what do you see on your end?
I'm seeing like maybe 12 slides.
Okay.
Uh, there you
Let
go.
me stop sharing and start again.
Oh,
Uh,
okay. Go ahead.
mm, okay. And do you see disclosures?
I do.
Yeah.
Yes.
Okay. So, spelled ketogenic wrong. Okay, we're going to talk today about, I'm excited to really share with you the work that we've done on ketogenic diets and just give an overview of the different applications of ketogenic diets and the monitoring. that are associated with optimizing a ketogenic diet. And this is my disclosures. My university, ensures that I kind of disclose our research support, and a lot of the ketogenic therapy that we've studied has been funded by Office of Navy Research and Department of Defense, and we've worked with federal agencies, industry, and various foundations, and we have some patents associated with what I'll be talking about. And then we also co-host the Metabolic Link podcast, and we also host a Metabolic Health Summit that talks about various applications of the ketogenic diet, and we have a variety of different speakers. So today I'm going to give like a broad overview of ketogenic diet therapies, and a ketogenic diet has been around for over 100 years, and it is technically a prescription diet, prescription metabolic therapy. And we say that because it's used very specifically. The original application was for seizures. Now it's used for drug-resistant seizures. As drugs came along, they largely replaced the ketogenic diet as an anti-seizure therapy, but now when drugs fail, the ketogenic diets are used for drug-refractory epilepsy in pediatric medicine and also in adults. And more recently, there has been an interest in ketogenic, what we call ketone or ketogenic metabolic therapy, which is more or less kind of like circumventing the need for the dietary restriction and inducing a state of therapeutic ketosis. And by definition, a ketogenic diet is the only diet that is defined by an objective biomarker, and that's the elevation of urine, breath, or blood ketones. So it makes it a very interesting diet to study because we can therapeutically titrate the dosage of ketones or adjust the macronutrient ratio, which is sort of intimately linked to the elevation of the ketones. And I'll be talking about sort of how that's monitored and how to adjust ketogenic diets. So there are a wide variety of applications for ketogenic diets. And when I started researching ketogenic diets maybe about 15 years ago, or a little bit more than that. And I think really the only application at the time was seizures. And now there's at least 20 different kind of applications for ketogenic diets. Some of these are evidence-based and proven. Some of these are emerging applications, and some of them are more investigative. So what's important, I think, for the clinical outcomes when looking at a ketogenic diet is really being able to induce a ketogenic diet, be able to sustain that therapeutic ketosis over time, and to monitor ketosis so you can correlate the levels of ketones and other biomarkers we'll be talking about as it relates to the metabolic management of a disease process. So, and that's kind of like our wheelhouse and what we've been doing. So our expertise is really designing and engineering specialized ketogenic diets for different applications, and then also developing and testing exogenous ketone supplementation that could be used in place of the diet to induce ketosis, or ketone supplementation could be added to a ketogenic diet. And that could be something as simple as medium chain triglyceride oil, like from coconut oil, to further augment the therapeutic efficacy of a ketogenic diet. So that'll be part of the discussion today, because it's the really important tools for shifting metabolic biomarkers. So I'm seeing if I could move the little box here. Oh, okay. So can you guys continue to hear me and see me okay?
Yes, you're doing great.
Okay.
Yep.
Great. Okay, so we're going to talk a little bit about the methods that you can employ to induce and sustain therapeutic ketosis. And we put that under the umbrella of ketogenic metabolic therapy, and we like to abbreviate it KMT. So there are a number of different, there's not any single ketogenic diet. A ketogenic diet is by definition a diet that, as mentioned, will elevate and sustain ketosis. So it is defined by that objective biomarker. The original ketogenic diet is called the classic ketogenic diet. It's very high in fat. It was used for pediatric epilepsy, more or less developed, by the Mayo Clinic and then Johns Hopkins under the sort of direction of John Freeman, and then later Eric Kossoff sort of defined the names for these diets. And so you have the classical ketogenic diet, which is very high in fat, and then the modified Atkins diet or modified ketogenic diet, which is more liberal with protein and not as much fat, 65% fat. And that diet is largely used in the adult population. And then you have the medium chain triglyceride diet. MCT oil is a ketogenic fat, and it gets, when you ingest it, it goes right to the liver via hepatic portal circulation and generates ketones. So that's the ketogenic fat shown below there. And then you have exogenous ketones. They can come in the form of beta hydroxybutyrate salts, diols, and then 1,3-butanediol is an example. And then there's different types of ketone esters. So the exogenous ketones are a hot area of research right now because they can mimic the ketogenic diet. And in some cases, in people that are unwilling or unable to follow a ketogenic diet, they can circumvent the diet. We don't think that's optimal, but we think when used in tandem with the diet, it could be optimal. And then there are various metabolic drugs that can induce a state of ketosis. So even things that cause a caloric restriction effect. I mean, I guess you could say even in some cases, a GLP-1 drug induces, caloric restriction and maybe even a mild state of ketosis. But the more classical ones are like metformin, and then there's SGLT2 inhibitors, which get your body to eliminate glucose, and that stimulates ketosis a little bit. And then you have 2-deoxyglucose too, which is like a glucose mimetic. But it blocks glycolysis, so it can induce a state of ketosis. So essentially what's happening is that you are shifting your body's metabolism by suppressing the hormone insulin, and that stimulates that augments fat metabolism peripherally, but also in the liver. And as the liver metabolizes more fat from ingested fat and also from adipose stores, the suppression of the hormone insulin and depletion of liver glycogen stimulates acetyl-CoA production, and then the accumulated acetyl-CoA can form these molecules, ketone molecules, and that could be acetoacetate, beta-hydroxybutyrate, and acetone. So ketones are energy molecules for, first and foremost, for the brain, the central nervous system. They are fuel for the heart and also the skeletal muscles. So there's also we can measure ketones in the blood, urine, and breath, as mentioned, and you could also measure the ratio of glucose to ketones, and this is called the glucose ketone index, or the GKI. And there are commercially available meters right now that actually measure the glucose ketone index. And I want to emphasize that because that biomarker is highly correlated not only to seizure control, but also the metabolic management of many disorders that I'll be talking about. And it's a very simple calculation. It's essentially the millimolar concentration of glucose over ketones. And in the US, we measure glucose in milligrams per deciliter. So to convert that to millimolar, you just simply divide by 18. And so a GKI of 1 would be analogous to having a blood glucose of 3 and a blood ketone level of 3, or blood beta hydroxybutyrate of 3. And then the typical person would really have to fast for several days to even achieve that. So it's a difficult metabolic biomarker level to achieve, but we can achieve that with diet and supplementation, and we know it's very therapeutic. So ketones are a source of energy, and they're powerful signaling molecules that are associated with all these mechanisms below here. And these are like a lot of the things that we study in the lab, the free radical production, the inflammasome, even epigenetic effects. So various metabolites, especially ketones and maybe lactate, directly can augment gene expression through different enzymes called histone deacetylase enzymes, and also interact with the histones directly to influence gene expression. So that's an area of basic science research that we have been focused on. In regards to just give an overview of the ketogenic diet research, it was largely stimulated by the Hollywood producer Jim Abrams, who actually recently passed away about a year ago. So I would have the opportunity to meet with him and incorporated him in my talks over the years, and we've held various fundraisers for his organization, the Charlie Foundation. So Jim was on Dateline NBC back in 1994 and talked about how the ketogenic diet helped his son basically control his epilepsy when everything else failed. So that I remember actually watching that episode of Dateline NBC when I was in college, actually in a nutrition course at Rutgers University at the time, and didn't really think that much of it. Didn't know that was going to be the trajectory of my career, 20 years later, 10 years later at least. And there has been, an explosion of ketogenic diet research over the years shortly after that. And you could just simply look at the PubMed peer-reviewed studies and I just did an analysis yesterday of 2007 to 2008, because that's when I got interested in researching the ketogenic diet and applying for grants. And in this year, the last year, there has been 665 peer-reviewed publications with the term on PubMed, looking at the term ketogenic diet. So, and a lot of people thought that the ketogenic diet was a fad. About 3 or 4 years ago, they said, oh, the ketogenic diet is kind of going out of, it was a fad and it's now tapering off. But that's really not the case if you look at the peer-reviewed literature. Maybe if a Google algorithm, but not so much the literature. In 1997, there was a movie called First Do No Harm about the ketogenic diet, and it starred Meryl Streep, who was a friend of Jim Abrams. And then that also brought a lot of attention to the ketogenic diet for epilepsy. So, and that also kind of inspired my career path too, just because I was studying seizures at the time. So you hear a lot about the ketogenic diet online for various applications, but I think it's important to understand, even a lot of people talk about keto. Many of them don't know the foundation of the original use of the diet, which is really for epilepsy, the clinical use. I guess if you go back really far, it was actually used in some cases in type 1 diabetes. In the absence of insulin, the diet could keep patients alive longer without insulin. And that's sort of was a controversial application, and it's kind of has interestingly reemerged. But in regards to the established clinical applications, epilepsy and seizure disorders, we have 15 to 20 randomized controlled trials. And I say 15 to 20 because there are versions of the diet that, like the low glycemic index diet, which is very low carb, but not necessarily ketogenic. So there's 2 or 3 trials related to that. And then some of the things that we study include the glucose transporter type 1 deficiency syndrome. For example, we have a mouse model of that, and there's also pyruvate dehydrogenase deficiency syndrome, where these are really, the ketogenic diet is the standard of care. It's the first line therapy for some inborn errors of metabolism. And then there are, various emerging applications and investigational applications. And I summarize the emerging applications here, and including the mechanism and the rationale for the use of ketogenic diets. So psychiatric conditions are a rapidly emerging application of ketogenic diets. So there are, over in the last 2 years, really almost an explosion of randomized controlled trials on clinicaltrials.gov, you'll see. And that could be for bipolar disorder, schizophrenia, depression, and even anorexia nervosa, which is the psychiatric disorder that actually kills more people than any other psychiatric disorder, I think. So there's a wide variety of research that did not exist 5 years ago that is actually being done now, and many of them are randomized controlled trials. So Alzheimer's disease and cancer are another topic that we study, and there's a good solid rationale for the use of ketogenic therapies for these things. And as you can see, a broad array, and this was taken really off PubMed, looking at various clinical trials, case series, and case reports. But there's a lot of emerging research. So yesterday, I looked at clinicaltrials.gov, and there are 447 registered clinical trials on clinicaltrials.gov. And this is really interesting because when I started this research, a while back, 15 years ago, there was like maybe 5 studies. And every year there's like, dozens of more studies added. And you have, evidence-based applications. There are a lot of studies looking at, as you can imagine, epilepsy and other seizure disorders. There are various disorders like Lennox-Gastaut syndrome, Deuce syndrome, Dravet syndrome that are seizure disorders, but maybe kind of separate from epilepsy. Cancer, cachexia, weight loss, type 2 diabetes, like these are the, kind of taken up most of the trials. And then, there's a number of other things being looked at like autism, migraine, and various inborn errors of metabolism. So, and then there's, I put that under the umbrella of evidence-based applications because there was prior research on there. And now there's a lot of investigational applications, as mentioned, for psychiatric disorders. There's 58 clinical trials. And, I think maybe 10 years ago, I know there was really none. COVID and long COVID trials looking at traumatic brain injury. And you would think, type 1 diabetes would be a no-no to study with a ketogenic diet, because with type 1 diabetes, you have the potential for diabetic ketoacidosis. But with type 1 diabetes, a low-carb diet or even a ketogenic diet can reduce the amount of insulin that a patient needs to use. And whenever you can use less insulin, that's a good thing, as long as you have, kind of tight control over, as long as you're monitoring glucose and ketones. So there's a number of emerging applications, even, alcohol withdrawal syndrome. And I was just served on a PhD dissertation committee for the use of ketogenic diets and ketone supplementation for alcohol withdrawal and benzodiazepine withdrawal syndrome. So they seem to impact various reward centers in the brain. So another area of research that we're very involved in is the use of ketogenic diets for cancer. And that could be brain cancer is really high on the list because of the seizures associated with it. But ketogenic diets restrict glucose availability to the tumor, but they also impact insulin and insulin signaling, which tend to be drivers of tumor growth. So on clinicaltrials.gov, here are all the different types of cancers that are being researched now with a ketogenic diet. And I think it's important to mention that in most cases, like probably 90%, 80 to 90%, the ketogenic diet is being used to further augment the therapeutic efficacy of the standard of care. So that could be chemotherapy, radiation, or immune-based therapies, including the checkpoint inhibitors. So this is another rapidly emerging area of research. And I think what separates the really good studies that are going to contribute to our knowledge and the studies that maybe won't contribute as much would be biomarker monitoring. And I think that's why it's really important to design a diet that actually achieves, for example, a low glucose ketone index, and that would be indicative of the diet. There are many ketogenic diet trials that are being done where the team's not even measuring ketones. So we don't even know if the diet is by definition like a ketogenic diet. So this has been acknowledged to be a problem. So there's, a consensus now among scientists researching this that we really have to focus on biomarker monitoring. So when it comes to implementation, biomarker monitoring really is key. So I'm showing some figures here of what happens when one fasts or undertakes prolonged fasting. So therapeutic ketosis, fasting ketosis will shift metabolic physiology from a sugar or glucose-based metabolism to fatty acid and ketone metabolism. So the panel on the left, it was research that was done at Harvard in the lab of George Cahill and Oliver Owen, where they actually fasted subjects for 40 days. So they had no food for 40 days. These types of studies can't be done now. It was done in 1967. And when the study was done, they looked at they looked at brain energy metabolism, the AV difference, so they could detect. It was a very elegant study. They looked at fuel flow to the brain and fuel flow of the blood coming away from the brain, and they confirmed that the brain was using ketones as an energy source. So as we fast, the level of beta hydroxybutyrate is the primary ketone molecule, gets elevated in the blood above the level of glucose after about a week. And then your brain has remarkable metabolic flexibility to adapt from using glucose to using ketones as an energy source. Now, prior to 1967, we did not know that. So it actually changed the medical textbooks. So the ketones then are functioning as an alternative energy substrate. And more interestingly, years later, Dr. Richard Veitch at the NIH, he spearheaded much of the ketone research and was an early mentor of mine. He passed away a few years ago. He was mentored by Hans Krebs of the Krebs cycle. So he was, there's a long history there of metabolism and ketones. So really kind of acknowledge that ketosis was very therapeutic, and they should not be only in the context of type 1 diabetes with diabetic ketoacidosis, were they a marker of metabolic derangement in the absence of insulin, but that's a very specific scenario. So in regard to therapeutic ketosis, you have a ketogenic diet or diets. You have a restricted ketogenic diet, which is simply a calorically restricted ketogenic diet. So you have calorie restriction in addition to a macronutrient ratio that you're eating that can further elevate ketones and reduce glucose. So that tends to be more therapeutic, especially in the context of epilepsy, especially for cancer patients, at least in cancer patients that have some weight to lose. If a cancer patient has a low BMI, this could, be detrimental in regards to skeletal muscle mass wasting. So, and another, method of achieving therapeutic ketosis is ketone metabolic therapy. So various metabolic substrates like medium chain triglycerides and different exogenous ketone supplements can be added to the diet as a source of calories to further elevate ketones and lower glucose. So in the case here, this is a 2010 case report of a woman that had a glioblastoma, and where they measured glucose, and you could see and glucose and ketones. So with diet initiation, you could see a sharp drop in the level of glucose. So the y-axis is here, and then a sharp rise in the elevation of ketones. And when the ketone level gets above the glucose level in millimolar concentration, that becomes the metabolic biomarker. We can measure this with the glucose ketone index. In the context of brain cancer, that is sort of what's observed. Brain cancer growth stops or significantly slows. And, it's not going to cure cancer, but it makes brain cancer and other types of cancers a more vulnerable target for other modalities because it's restricting cancer growth and metabolism. It also reduces some of the protective mechanisms that tumors use to protect themselves, like endogenous antioxidant mechanisms. More recently, we wrote a review entitled The Clinical Research Framework Proposal for Ketone Metabolic Therapy in Glioblastoma. And we go very much into the deep science. I was an author with 49 other authors, from many different institutions in the United States, some of them in Europe. And it was really important to acknowledge that the big lever here in using ketone metabolic therapy for glioblastoma is achieving and maintaining a low glucose ketone index. So this was a figure, the upper right-hand panel on your screen was a figure of showing ketone metabolic therapy initiation and what happens with blood glucose going down, blood ketones going up in the context of initiating a well-formulated ketogenic diet. And then if the individual or the patient therapeutically fasts, you could further elevate ketones and lower glucose, but not all patients are capable of fasting or would want to fast, especially if they're underweight. If they're overweight, then that could be a different scenario. And this is just, an example in the middle here of reduced compliance. And it could only take 1 or 2 carbohydrate meals to quickly kick you out of ketosis and kind of change your metabolic physiology in a way that could, enhance tumor growth or trigger a seizure. So kids that have epilepsy, they could eat 1 piece of candy and that can trigger seizures, believe it or not. So it's really, the brain is very sensitive to any metabolic perturbations, especially once you've achieved ketosis. So this would essentially have to be maintained until tumor growth was managed over time or the tumor was eradicated. But it's also important to acknowledge that ketone metabolic therapy for brain cancer is just one part of a big multi-component therapy that involves other metabolic-based drugs that target glucose and glutamine, and then there's redox therapies that can be added on to that can help. So we don't have time to go into it, but I just want to show you sort of the clinical research framework and clinical framework for this type of therapy specifically for brain cancer. So there are similar projects being done now discussing the clinical research framework for ketone metabolic therapy, for example, for schizophrenia, for bipolar, for type 2 diabetes, and for other different disorders. So what's really important in regard to conducting research and also just being able to correlate the outcomes of the patient with metabolic biomarkers is what I like to call biomarker self-monitoring, because it's really up to the patient. That's a patient that has sufficient oversight by a registered dietitian, by the clinical team, to periodically during treatment with ketone metabolic therapy to measure. Urine ketones are really easy to measure. It's very cheap. It's obviously non-invasive. Newer devices are coming out to measure breath acetone, breath ketones. So I've experimented with all these things. I have all the different devices, and breath ketones are a viable way to measure ketones, especially in kids with epilepsy who do not like to get their fingers pricked. Breath acetone levels correlate very tightly with seizure control. So, a child blowing into a device like the Keto Air device is much less, traumatic, I guess, than having to use a lancet and prick the finger to get blood. However, blood glucose and blood ketones are really the gold standard, and there are different devices commercially available that you can get on Amazon, on Walmart, CVS. So one is the Precision Extra, and then you have the Keto Mojo device. And emerging technologies, for example, the continuous ketone monitors are what we do research on, looking at continuous ketone monitors really as a behavioral tool to change a person's dietary pattern and to make them more metabolically aware of the types of foods that they're eating and the amounts of food that they're eating, because you can set the parameters to stay within certain ranges. And if you go out of that range, then the monitor will beep, your phone will beep and alert you that you've eaten too much of certain carbohydrates and your glucose is out of range. So here's, for example, some data from my continuous glucose monitor where I ate a keto cereal. There are many ketogenic products that you'll find in the stores. Many of them are listed keto, and this was a very popular ketogenic cereal that you'll find in Costco and Walmart or whatever. But when consumed, it caused a relatively large spike in blood glucose. And if it was truly a ketogenic cereal, the level of carbohydrate would not elevate glucose out of that range. And what often happens when you consume carbohydrates is that you get a spike in glucose, and then you have a postprandial dip in glucose from the insulin that's secreted from the glucose dip. So continuous ketone monitoring are really important tools that patients can wear, and the data goes to their phone and it goes to a data bank where the physician or the clinical team can basically observe tight control and compliance to the ketogenic diet or different metabolic therapies. And another tool that I'm experimenting with right now over the last couple of months is continuous ketone monitoring. So in addition to measuring glucose, we can measure in real time ketone production. So these tools are going to be really important for the research we're proposing to do at Moffitt Cancer Center and in other clinical trials. So in regard to continuous glucose monitoring, the optimal level is to really, you want to keep your glucose level under 120 milligrams per deciliter. So if you can follow a dietary pattern that achieves that, that would be really optimal, reducing glucose fluctuations, we think. So we know sort of it's the case for, people with type 2 diabetes, but these are sort of guidelines that are being established now for prevention and for optimizing your metabolic health for chronic diseases. So with a team of people, we've sort of published this. It's on the Levels Health website, and there's maybe about a dozen different endocrinologists and doctors that work in this area. However, if your glucose is consistently spiking above 180 milligrams per deciliter after meals, the postprandial spikes in glucose are associated with derangement in other metabolic parameters. So that includes like insulin levels, hemoglobin A1C, and even blood pressure. So these are, I'll have like ranges, optimal, normal, and high for all the different biomarkers I'll be talking about. So blood pressure is really not talked about enough, and I think it's not a blood biomarker for sure. It's not something to measure, but it's really important to measure blood pressure, I believe, at home, because many people, including me, have things like white coat hypertension. So when you go into the doctors, my blood pressure is a little bit higher than it normally is at home, and there are devices like the Omron device at home that you can measure. I have the same device here, so that I use and we use for our studies too. So optimal levels are, you want your systolic to be under 120 and your diastolic to be under 80, and elevated by definition is like over 120, 80. So ketogenic diets, interestingly, can sharply reduce blood pressure. And if someone's on blood pressure medication, it's important for them to titrate the dose, to often have to titrate the dose down and to reduce it. And maybe many people can get off blood pressure medication. So there's a number of different reasons for that. Ketogenic diets tend to work pretty quickly when it comes to reducing blood pressure, because the diets do have they have a diuretic effect and they have a natriuretic effect, which means they get your body to reduce water and sodium. So this can sharply reduce blood pressure over time. So it needs to be monitored. So fasting glucose or continuous glucose monitoring, which we already talked about, the sensors like the Abbott sensor and the Dexcom sensors typically last about 14 days. If one was to use a continuous ketone or glucose monitor, once or twice a year, that's going to be very informative. However, if they don't want to spend the money for that, now they're over the counter. You can just simply get a $15 to $20 glucometer and then measure your fasting glucose. Optimal levels should be under 120. If it's over 126, your fasting levels, that's by definition type 2 diabetes. If you can measure that 2 or 3 times, that's type 2 diabetes. So you want to make sure that your level is under 120, and high levels should be, you should measure that multiple times throughout the day, because your glucose levels can change. For example, some people, when they wake up in the morning, your cortisol is high, you could be a little bit dehydrated, so your glucose could be trending high. So you want to make multiple measurements throughout the day. Another biomarker that's super important to measure, probably the most important cardiometabolic biomarker that is not part of a comprehensive metabolic panel, like when you go in and get routine blood work. Interestingly, for reasons that I still don't fully understand, the most important one of the most important metabolic hormones is insulin. It's not on a comprehensive metabolic panel, but but you can ask for it to be done. And if you say you're just wanting to check if you have diabetes in the family, or you want to just keep observation over insulin, it's usually covered by insurance if you ask your doctor to add insulin. So the optimal levels for insulin are between 2 and 6 uh, micro IUs per milliliter, and there are different home kits like blood spot cards that you can get to measure your insulin levels at home if you don't want to go into the lab. Normal ranges are typically between 2 and 15. We recently, about 2 years ago, we did a study with normal people and found a range of insulin levels. Some were as high as like 50 or 60, and we put them on a low carb diet or a ketogenic diet, and that significantly went down with ketogenic diets. And we know it's really important to reduce insulin if you have cancer, because insulin is a potent growth stimulus for many cancers, including lung, breast, GI cancers, and others. So, and many of the drugs that are in development and testing now, like the PI3 kinase inhibitors, sort of target that insulin pathway. Hemoglobin A1C is another really important biomarker to measure. And I bring this up because it's typically not part of a comprehensive metabolic panel, but it gives you an aggregate measure of your blood glucose over 3 months. And high hemoglobin A1C is associated with cardiovascular disease, including high blood pressure, nephropathy, neuropathy, and retinopathy. So, and also various inflammatory disorders. So weight loss is your biggest sort of hammer for reducing hemoglobin A1C, but low carb diets and exercise can independently lower hemoglobin A1C. So just to reinforce that, a low carb diet and ketogenic diets can independently lower your glucose and hemoglobin A1C independent of caloric restriction. So it has so it can sort of beat a standard American diet if you calorically restrict that. Optimal level is under 5.2. That's kind of hard to achieve, but some people can do it. And normal levels are typically, 5.7%, and then your pre-diabetes range, 5.7 to 4. So, and the overt diabetes would be over 6.4%. So really important biomarker to track, and one that's responsive with ketogenic diets. There are home tests that you could use, like A1C Now, that I have used to look at hemoglobin A1C. High sensitivity C-reactive protein is also a really important cardiometabolic biomarker and tends to be elevated. More and more research is pointing to elevated CRP in obesity, heart disease, diabetes, Alzheimer's, leaky gut, cancer, sleep disorders, psychiatric conditions. And it's really important to monitor that. It's also indicative of autoimmune disorders. So ideally, you want your HSCRP. Now, HSCRP is high sensitivity CRP, and it picks up CRP at lower levels, has a better sensitivity and specificity. So adding this to a comprehensive blood work is usually $30 to $50. Sometimes insurance covers it, sometimes not. But ideally, you want it under 0.6. Average, most people average about 1 to 3. I noticed that if I transition from a ketogenic diet where my HSCRP is 0.1, very low, and transition to eating a higher carb diet and not changing calories, my HSCRP jumps up some. And I see this as kind of a trend in that people who are more on high carb diets and they transition to ketogenic diets, it lowers their HSCRP. So, and the last sort of constellation of biomarkers I want to talk about are blood lipids, and this can get kind of complicated, but ketogenic diets typically lower triglycerides, even when you double upwards of fat intake by twice, but lower carbohydrates, blood triglycerides typically go down, paradoxically. HDL cholesterol typically goes up, and ApoB and LDL may go up too, and that can be concerning for some people. An elevation of LDL cholesterol A better biomarker for LDL is apolipoprotein B, and that's a better biomarker. So we tend to see it doesn't change. It often comes down in people that already have type 2 diabetes or metabolic syndrome, but in normal healthy people, it tends to creep up sometimes with ketogenic diets. And we're unsure of the cardiovascular risk that it presents in normal healthy people that have an improvement in other cardiometabolic biomarkers. So that's an area of intense investigation. My ApoB and my LDL did go up significantly on a ketogenic diet when everything else kind of improved. And not to get too much into the weeds or the details here, but there's a drug called Zetia. Generically, it's called ezetimibe, and it blocks the MPC1L1 receptor in the gut specifically for cholesterol absorption. This particular drugs does not have the side effects that statins have, for example, and it tends to lower, in my case and in other people, it can lower your ApoB and LDL cholesterol without the side effects of statins. So I just want to briefly mention it here because that is a concern. That's the one biomarker that I think ApoB and LDL is a biomarker of most concern right now and is under the most research as it pertains to cardiovascular risk with low carb diets and ketogenic diets. So we do have tools in our toolbox that we can address the elevation of that biomarker with different tools. And I think it can be done in a way that has little or no side effects. So vitamin B12 is something that is a biomarker that we should be checking too, especially as we age. There's different things that decrease our absorption, like intrinsic factor over time. So these are the optimal ranges that you would want as you age. And it's important to supplement with a methylated B vitamin if your levels are low. That'll bring it up fast. So here's a summary of the blood biomarkers that I talked about. There are side effects of ketogenic diets. I just want to quickly highlight. There are contraindications like pancreatitis, liver disease, fatty acid oxidation disorders, carnitine deficiency. If you're on a ketogenic diet, you could become deficient in carnitine because there's so much fat oxidation. Carnitine's a carrier for fat metabolism. And in females too, I want to mention that the clinical, at least in the world of epilepsy, there's a higher potential for amenorrhea and reduced active thyroid, the T3. But we don't know kind of what that means. And I think it has to do sometimes with the protein restriction. So if a ketogenic diet is adequate or sufficient in protein without caloric restriction, that is often not the case. But if it's calorically restricted and protein restricted, amenorrhea and reduced thyroid can be a problem. So in summary, and I think we're running low on time, but I just wanted to kind of just give an overview of the current research that we're doing. We do a lot of basic science research, but we're really working to advance the clinical applications and implementation of ketone metabolic therapy with the different biomarker tools that I discussed and the specific biomarkers. Self-monitoring is also really important. And it also empowers the patient to be able to have that level of oversight and be able to see, for example, their glucose level in response to a meal in real time. And that can be a behavioral tool and a teaching opportunity for patients as they're sort of navigating the best diet for them. And I'll say that there are meals that will elevate glucose sharply in some people, and in other people, it'll have no effect at all. And I can just say that my wife and I, for example, can eat the same thing and we can have totally different responses if we're wearing continuous keto. So that's why I think these, N of one experiments, if you want to call it that, or personalized monitoring is going to be really important for patients too, as we move into clinical research with this. The glucose ketone index is a super important tool for monitoring patients that are using a ketogenic diet or ketone supplementation. And there are a wide variety of tools in the toolbox to lower the glucose ketone index, including exercise, aerobic exercise, even strength training, building muscle. That's your metabolic, sink. The more muscle you have, the more metabolically fit your muscle is, then it becomes a better disposal tissue for glucose. if you want to use that term. And there's various metabolic drugs that I think are really important and can factor in, can lower glucose and elevate ketones. And there are drugs like statins or ezetimibe, which tends to have very little side effects that can be used to lower your LDL cholesterol and ApoB if that does become problematically high when you initiate a low carb diet or ketogenic diet. So we're moving a lot of the things research that we're focusing on now in preclinical models to clinical research, and really hoping to advance some of the things with Moffitt Cancer Center and also the Alzheimer's Center we have here. So I want to thank you for your attention, and I'll be happy to address any questions you may have. And also want to give attention to my lab. They have done most of the work. I'm the person that talked about it, but they're the ones sort of in the trenches doing it. And we also host a metabolic health summit where we bring a lot of speakers in, academic, and a number of people to talk about the application of various metabolic therapies, including different dietary therapies for different disorders. We do think food is medicine, and we want to move kind of the field in that direction.
Amazing. Thank you for the wonderful talk. I, for one, have just followed the metabolic link, so I'm looking forward to listening to this podcast. Amazing. I think we have time maybe for one or two super fast questions. I have a bunch, but I'm going to open it up to go ahead, Dharma. Why don't you start us off?
Good morning. Thank you so much. This was just a fantastic talk. I really appreciate your time and sharing your expertise. I've heard recently that when we supplement with exogenous ketones like BHB, that it could make it more difficult for the body to, or maybe it slows the body's ability or willingness to create its own. Could you talk a little bit about what we know about supplementing with BHB when we're moving people onto a ketogenic diet?
Yeah, that's a good question, and one that I get often, actually. In pretty much all scenarios, we usually advocate for the supplementation of exogenous ketones, whether that's a ketone salt or a ketone ester. We combine it with medium chain triglycerides, which further stimulates your body's own ketone production. So if you were to take a large dose of a ketone ester that would elevate ketones rapidly, there's a counter-regulatory mechanism where the elevation of ketones in the blood will trigger the pancreas to secrete a little bit of insulin, and that insulin has an anti-lipolytic effect. So it decreases beta oxidation of fatty acids in the liver. And that's the driving sort of force for ketogenesis, for ketone production. The suppression of the hormone insulin elevates beta oxidation of fatty acids in the liver. And if you ingest a large dose of a ketone ester, we do not see that with the ketone electrolyte salts. For example, like the ketone salts are like the beta hydroxybutyrate spread across sodium, potassium, calcium, magnesium. When that's consumed as an electrolyte salt and you measure insulin, for reasons we don't fully understand, you can elevate ketones, 1 to 2 millimolar rapidly, but the electrolytes tend to block the insulin, but they also maybe delay gastric absorption, where you don't get the spike in insulin associated with the big dose of the ketone esters. A lot of work we do is with the ketone esters, and to get around that problem, we mix the ketone esters with MCT formulation, and then that tends to reduce that insulin. So yes, that's a very good point. A lot of people don't even know that you could potentially reduce your own ketone production if you were to consume a large dose of a ketone ester. And that could be counterproductive for some people.
Oh, that's just fascinating. Thank you so much.
Wonderful. Well, I think we are at time. So this was just amazing. Thank you so much. We'll make this recording available. And again, thank you. And everyone, if you want to reach out, please do so. Follow the podcast, and hopefully we'll be able to rope Dominic onto another presentation soon. Thank you again. Much appreciated. Take care, everybody. Bye-bye.
Thanks for the opportunity, Josh. Appreciate it.